doctors in the room, we will be moving forward with another panel discussion. This time, it is healthcare policy and regulatory frameworks, encouraging innovation for affordable cancer treatments. In a world where every medical breakthrough holds a promise of hope, our panelists will unravel the dynamic interplay between policy, regulation, and the search for accessible cancer treatments. It's not just a discussion. This is an interactive exploration where your insights and questions will shape the conversation. Our moderator is Dr. Yanfeng Wang, if he can make his way to the stage. Yes, a round of applause. And also joining the panel, we have Minerva Kalada, MD. She's just made her way onto the stage. Also, Josh Forst, Tushar Shrivastava, that's it, and Dr. Gabriele Soldini. That is your panel. Thank you very much, Doctor. Stage is yours.
So why don't we knock a little bit, make sure it works. Okay, you're not on? No.
Is it?
Try again. Okay, so here we are. Masa ulunor, is me Alex Wang. Good afternoon, my name is Alex Wang. And Buenos tardes, mi nombre Alex Wang. Today we have a great panel, so before we start, I would like our panelists to introduce themselves. Maybe start from Josh.
What's going on, everybody? Am I coming through?
Can people hear him, or we need to fix the microphone?
Is this one working?
Yeah.
There we go.
Okay.
How's everybody doing? I'm here from the great state of New Jersey. It's a long ways away. Been a broker for several years, doing both health insurance for individuals, small groups, Medicare and Medicaid. So a wide array of clients that I deal with on a regular basis. So I've gotten to see a lot of things from different perspectives, depending on the type of programs they're in, as well as the income brackets they're in. So I've got a nice contrast to share.
Yeah. Thank you, Josh. Next, we have a panelist from Italy, please.
Hi, everybody. I'm Dr. Soldini Gabriele. I'm a consultant in general surgery in a private hospital in Italy that is affiliated with the public system. So it's between the two systems, the two way of treatment. I treat cancer every day, gastrointestinal cancer, especially colorectal cancer.
Thank you. Next, we have a CMO from hospital.
Hello, this is Minerva Kalada, MD. I'm actually an ER physician. I used to be a pathologist, and also I'm the chief medical officer for our county medical group. I also am a past adjunct professor for UCSD of medicine and a past clinical instructor at UCLA. Also, I have been a medical consultant for the California Medical Board.
Yeah. Thank you. Finally, we have an expert from London.
Hello, everyone. This is Tushar. I'm a CEO of Connect HUR, and this is a field I work in, is a health economics and outcome research. Maybe you're hearing for the first time, but we're going to talk about in that later on as well. And nice to see you all.
Yeah. Thank you, all the panelists. So today, we have a great lineup. And also, based on my experience for many years, for your information, when I first went to graduate school at UPenn, I was in neuroscience program to read people behavior. The way to look at the panel, are they going to give you a straight answer, or they're going to hold back a little bit? Look at their leg formation. When they are parallel, they give you honest answer. When they cross, they are not, they're holding something back, okay? So pay attention to their leg languages. So what I want to say today, oh, by the way, I am from Stanford University. I am their full-time employee of the business development director for School of Medicine. So I'm very impressed with the panel because we have the first-hand information people from the chief medical people of the hospitals. we have people from HEOR, which are very important aspect to look into health economics. And also we have people speaking on behalf of the insurance, okay? So today, this will be a very rich, knowledge-rich panel. So let's start the first aspect, because we are talking about the cancer treatment. With so many new technology and innovation emerge, and also the cost on the other side, we have to concern. The regulation also within a lot of things with the innovation aspect. So it's very helpful for every panelist to give your prospect, just in high-level overview, what is your open statement by looking into this topic. So in this way, I think we will start with the lady, the CMO, please.
Well, I think it is actually important talking about what's new in cancer. And there are many advances, especially using the CAR T cell. It's a great innovation. The problem with it is kind of like health industry or insurances are not covering most of it. Being the chief medical officer, we have many patients that we have to plead to the insurance to cover such a situation. The CAR T cell therapy is a way of instigating the T cell to be permanently after injection to fight, to instigate the immune system of the body to fight the cancer cell. Your T cell is the memory cell of your body. So you have T cell and B cell. The T cell is the memory cell that basically is like the radar that identifies the cancer cell. By sensitizing that initially, it makes it more informed of recognizing the cancer and continue to instigate or educate or like help the immune system to fight the cancer cell on a chronic basis. But I would leave it up to most of the people who know about the insurance and the coverage, and it's really very difficult to have.
Thank you very much. We are going to talk more in detail for the next round of the questions. Thank you so much. So next, I would like to look into Tushar. By the way, you are the expert of HEOR, Health Economic Outcome Research, which have been very popular and useful for the past 10 years. And by the way, when I first heard that one 10 years ago, I mistaken that one as HERO, hero. So Tushar, I may refer you as Tushar the hero. So what is your angle on this aspect?
Okay, thanks. Yeah, so just a brief about HEOR, Health Economics Outcome Research. So we, like HEOR, as a HEOR professional, we work as a bridge between payers, patients, manufacturers, and we try to demonstrate the value of the healthcare technology from manufacturer perspective alongside if payers are, investing in that particular healthcare technology, then are they first of all, the question number one arises that if it is affordable, and if it is affordable, then is it value for money? And when I say value for money, it is not only about costing side of the thing, it is also about long-term effectiveness of that particular healthcare technology, and again, thinking in the sense of quantity of life alongside quality of life. And one of the key tools which we use as an HEOR professional as quality adjusted life year is kind of a mix of quantity and quality of life. So that's kind of the tools which we use, and for this particular topic, I think this is very important because it's all about innovation. Innovation will go on, like in the cancer therapy, like there are a lot of innovations, immunotherapies, there are targeted therapy, there are CAR T cell therapy, as Elena mentioned, that is also there, but it's becoming unaffordable day by day. And since we are talking about affordability as well here, so we also have to understand that affordability, like there's a simple answer of it, like why we are having that, high cost drugs, like at the first place, why we should have that, like lower down the cost, we should be good enough, right? But we have to understand that it is not possible. From pharmaceutical perspective, it is like there are a lot going on in R&D, and like ideally, like as a statistics perspective, then 1 out of 10 trials are going from phase 1 to phase 3, and then it is reaching to the patients, and it is showing efficacy, it is showing safety, etc. But so there are a lot of money going in, and as a pharma, they have to understand and they have to be inspired to do more and more in R&D, and for that they need some return as well. But yeah, I agree that there are some barrier also we have to think about, and it should be more or less depends on what value that particular healthcare technology is bringing in on the table.
Yeah,
So,
thank you, Tushar. So, Josh, when I first met you, I feel safe and confident without knowing your insurance. Just look at how strong you are. You as a muscle man look like a bouncer, okay? So what is your angle on this topic?
Well, from a broker's perspective, it's quite interesting. I say the biggest things that I run into with my clients is the barrier to entry. A lot of clients that have to go through these therapies and different treatments have a lot of issues with billing. They'll get massive bills in the mail because they never received the prior authorization. So a lot of times, hidden costs that are coming to them in the mail that simply could have been rectified with doctors doing the prior authorizations. But I mean, truthfully, if they need these types of treatments, that shouldn't be happening. And then accessibility is an issue as well. Whether they're in rural parts of the country and they have to drive, 40, 50 miles to the nearest doctor, and then they go there and they're like, hey, I didn't even like this one.
Yeah.
Or they're in underserved communities and they don't have the best quality of care. Those are two of the biggest hurdles I see happening there. And then, of course, the different types of treatments and the prescriptions they have to deal with. And depending on what types of programs they select, I think a lot of these should remove, the barrier to the cost of these drugs. Because I've seen, for example, like Mark Cuban with that leukemia drug, he removed the pharmacy benefit manager for one of the drugs, that leukemia drug, and it went from $3,000 down to $54 just by using that. So creating some competition there to remove, the middleman that's running up those costs.
Very good point. I already heard some points already echo for what Margaret mentioned from different part of the patient journey. So finally, Gabriele, I believe your hospital may be the oldest one in the whole European region. I haven't had a chance to talk to you yet, and I'm just curious, is your hospital include patients like Medici family or Michelangelo, those kind of famous people in case, But what is your angle from Italy, or you are more knowledgeable than other people about the European system? Just in a kind of brief language, how do you approach this topic?
With the innovative, I think in Italy it is quite different. We have a strong public health system, and the patients don't have to pay for the treatment.
Yeah.
Our problem is the waiting list, because we have a priority for cancer, but for some kind of cancer, we have to wait.
Yeah.
And the private system, the private way is good to become all quickly, and the patients can choose the surgeon, choose the place of the treatment, and choose the time of the treatment. I think this is the real plus of the private system.
Very good point. By the way, I like you a lot. If I don't like you, I will invite a panelist from France or Spain, because those are the natural enemy argue against you on soccer. So they will argue you to the bone, okay? So thank you for all the panelists. So we are going to use one of the latest progress of the cancer treatment. Most of the people, I assume, heard about the CAR-T, which is a chimera antigen receptor treatment, one type of the new therapy treatment specifically used for cancer. By the way, for people in the room, if you haven't heard about this, raise your hand. I will briefly explain to that. Anybody haven't heard CAR-T? Okay, so just in very brief language, because I happen to be cell molecular major for training in PhD, CAR-T refer to, if you want to treat the cancer, you use a genetic method to modify the antigen-specific receptor that can be useful target on the cancer antigen, so that your cell will be converted as a weapon to go after those kind of cancer cells, okay? Essentially, they are using your own resource, your own cell, by modify your genetic molecule so that they are going to go against the cancer. And that is one of the latest development over the past few years, already makes some impact for both sides of the Atlantic, I would say, okay? So here the issue for CAR T is getting approved for some cancer indication, including some difficult leukemia, lymphoma to start with. Solid cancer maybe a little bit after, okay? It shows very good efficacy. I wouldn't say it's one-time treatment. You give one shot and that's all. It's not a kind of genetic correction stuff. But it shows a lot of promise. It indeed can avoid a lot of complications. You do not need to be in medication for the whole life long, hopefully. But the price tag can be anywhere between $500,000 to $1 million. Okay? So by saying that we are facing a cost, there is innovation. We need to consider affordability and sustainability, which is why Josh is here, can speak from the insurance side. By saying that, I want our panelists to use CAR T as an example. We wanted probably more and more different types of the cancer will also benefit from the new treatment. However, with the price tag is so high, what is your take on that? So we still start from the patient side. Maybe Mervyn, you're the one who interact with the patient directly. You take the first step on this part.
Well, I would say actually the involvement of the patient, basically, there are many patients, like you mentioned, are on the waiting list. But I would say because like we are the first people to discover such therapy, it has been getting better. So I would say that there are many people have been informed about it. And many, it has been used also for kids for lymphoma, and it has been used for leukemias. And so there is a lot of people are well informed about it. And in the same time, there are more cancer patients are really more inclined to be kind of using the therapy. When a cancer patient is very desperate and any new type of trial, they will go for it. And I know that there are two patients I know in fact that there are several societies, like there was different people that they donated the money to help them. And so there are many agencies, like I know Scripps Hospital in San Diego area, that they have many programs that they help several patients that I have been acquainted with. So it's getting better. I wouldn't say it's totally blocked. It's definitely getting better.
Right. By the way, just for my knowledge, CAR T treatments are still the outpatient treatment, right?
I'm sorry, could you repeat the question?
My question is, in order to implement CAR T treatment to the patient will be in the outpatient setting. Is that correct?
Yes, there are several of them that they are an outpatient. And there is, in San Diego in particular, Scripps Hospital and UCSD, they have a lot of programs for outpatient treatment.
Yeah, and it sounds like a lot of testing before and after genetic marker or cell indicator need to go back to the university
just
centers.
to match, to be able that they are going to be in a successful trial for that. We actually do also have a big program in Southern California in which that we have one of the most well-known cancer treatment area that they opened recently. And they have many cases that they come from everywhere.
Yeah.
We have lots of cases, actually, our area in particular, we have biggest number of lymphoma and leukemia.
Yeah.
So
That sounds very encouraging. We already heard your area for a lot of practice is a kind of pioneer of the new wave. Okay, we are glad to hear that.
Definitely.
Yeah.
Yes.
So maybe we switch to Italy. What's going on, and are there a lot of CAR T treatments start ongoing?
Sorry, can you repeat?
So for your country, Italy, is CAR T a new thing, or CAR T is in trial, or CAR T already start to implement to some cases?
The problem is that the time of diagnosis and the kind of treatment. The time of diagnosis is really a problem nowadays because if I'm a patient, I have to do a TC scan with public health system. I have to wait 2 months or 3 months to do a TC scan. And this is a problem because we have a lot of delay of diagnosis. And the second problem is the kind of treatment. For cancer, we have a multidisciplinary approach. The way of treatment is defined by oncologists, surgeon, radiologists, and all the discipline. But not every place can do the same treatment.
Yeah.
One example, we can perform surgery by open surgery, laparoscopic surgery, or robotic surgery.
Yeah.
Not all hospitals have robotic surgery. And it depends on public system and some private hospital that don't have enough money to pay the robotic surgery. So in this kind of setting, a place of insurance can sustain this hospital, but only public system is quite difficult nowadays.
Yeah. Because you mentioned robot, I happen to know the most popular and a lot of people say is the best robot brand is Da Vinci. So the best medical robot is Italian, right? Okay. So we also need to come down to the outcome because we put in so much effort investing in new technology like CAR T. So there must be pharmaceutical company, biotech company, or potential client consult with you to share without disclosing detail with the client. So what is feeling from the HEOR aspect when you look at the CAR T?
Yeah, definitely. So from HEOR perspective, so within HEOR, what we talk about the value demonstration, value of that particular CAR T therapy, in this particular case, CAR T therapy. And we have to think about not from the short-term perspective, we also have to think about from the long-term perspective. Yes, it is unaffordable at the moment. Yes, it is costing huge amount. And again, but it is at the start of the therapy. Like at the start of therapy, this amount is totally going into the treatment of the patient. But if you have to think about the long term, and we also have to think about what patients are requiring, like what the patient's goal is that with these, like they can access these innovative technology with, with not too much pressure on their pocket in terms of out of pocket, like the co-payment, if there is a multiple private plus public healthcare system, or if it is a public healthcare system, then public healthcare system already reimburse that particular, treatment and therapy. So we have to optimize all of these together, and we have to think about from the long-term perspective, and even on the safety side of the thing. From manufacturer perspective, from pharma perspective, if those CAR T therapies are not going out and not getting reimbursed and not getting payment for those things, what is their inspiration to do more research and development in this space? So that is another challenge in this case. From payers' perspective, they also want to understand that, okay, if they are ready to put the money in for this CAR T therapy, is it, first of all, is it affordable? And if it is affordable, then is it like a value for money? Like for them, their goal is to maximize the healthcare of the whole nation or whole region, depends on what are the target group and target places. So in this case, I believe from payers' perspective, from a regulatory perspective, we have to think about a lot of alternative payment modeling approach. It's not just straightforward fee-for-service approach, which is quite common in the public healthcare system, where post-consumption of the drug and post-consumption therapy, payment is getting to the manufacturer. It is also about like fee-for-service is an alternative of, say, you can say that it's a volume-based healthcare, like where the number of CAR T therapy going on, and then the reimbursement is going on for those particular, the pharmaceutical companies and the manufacturer. So it should be around the direction of a value-based healthcare, where we are also talking about the clinical efficacy, we are also talking about long-term effectiveness, we are also talking about safety and quality of life, and taking all together to come up with the conclusion that, okay, if this particular therapy is value for money, or is it basically, it is efficacious, like it has shown that it can increase the patient's life year, it can increase the patient's quality of life, but are we ready to put the money in for that particular therapy?
Yeah. By saying that, there are different portfolio of innovation for the similar or the same indication ongoing. For example, this year at JP Morgan conference in January, the hottest topic, including the cancer treatment, is antibody conjugate, those kind of treatment, which potentially can be much cheaper and show very good efficacy for some. So have people asked you to compare the CAR T and the antibody antigen in the HEOR level, which one seem to be more affordable or more sustainable?
Yeah, definitely. Like, if we go to compare CAR T with, the therapies which you mentioned, like the cheaper one, like it's an with equal efficacy or maybe a bit of lower or a bit of higher, then CAR T is never coming out to be the cost effective, right? In that sense of a long-term perspective, like it can never be the cost effective. But we also have to think about that, okay, then how the safety profile looks like, how the quality of life perspective looks like. So for those particular drugs, say for example, if it is a chemotherapy, which may be lower cost, which does not have that much of a burden in the sense of teaching hospitals as well, like how to care about that and how to provide that particular chemotherapy to the patients, because it is already there from so long. So it turns out to be that how much we are considering the additional factors in, like what CAR T is bringing in this perspective, how much to waste the resources which are there and which may be getting wasted overall. So there's one statistics, which is a very big statistics in this sense, like which is from IOM, that in the world right now, including all the disease area, around 750 billion waste cost goes in just because of the inefficiency, because of the wasteful resources. So which means that how we are managing that particular element, because overall burden on the healthcare system, it's a small element which will turn out to be the total cost, and we have to optimize that total cost, not only the therapy cost.
Very good point. We are getting into detail. By saying in the detail, in American, the saying is devil in the details. And from my understanding, in fact, the detail in business, that's a number, that's a money, So somebody need to pay for that. Josh have a lot of knowledge in insurance. So what is the initial or the current reaction when insurance hear, oh, we can treat this indication with CAR T, but here the financial you're looking at. So what is your feedback from the insurance, their opinion?
Yeah, we haven't had anyone get approved for any of that type of therapy.
Not a single insurance company officially.
Not a single insurance carrier in the U.S. has approved that for
That's
at least
why
my clients.
including commercial insurance company and also including government Medicare, Medicaid, I assume,
Correct.
right? So do you get the impression whether they speak that one loudly or they do not just implicate, they think the price tag, they need to wait a little bit to see how far the price tag can go?
It's interesting. I think some cost transparency is going to put that to rest. Being able to let the consumers see what these therapies and procedures actually cost, and then what's being passed along to them is really going to put that to bed. So once we can actually figure out what does this actually cost, we can come up with cheaper alternatives and create some more competition to really drive down that price to make it affordable for the consumers.
Yeah, it sounds like the insurance, they are relatively reasonable and try to balance different kind of cost and benefit, including patient family, their advocate. Obviously, they are very loud screaming for that, okay? On the other side, you are looking for to share what is HEOR look like, different kind of opinion, whether there's a better option to bargain for or wait a little bit for conjugate coming up, right? Or you are looking at a Biden government or whoever take charge of FDA to see what kind of policy and also look after your own financial, right? Very interesting. So by saying that, CAR T is a very good example. So the topic today is affordable, or in certain way is sustainable. We want to cure the patient. CAR T start with smaller segment of cancer, but cancer is a large disease. Eventually, cell therapy probably can cover, I wouldn't say all of them, but probably most of them. But with price tag so high, The innovation, not only R&D, manufacture, commercialization, but also regulatory, they have important thing. FDA approval can be very long, can be very expensive. So there are different type of innovation. So based on the panelists, I want to encourage you to think about, is there a few places in the whole journey of the drug developed to the market that the agency, the stakeholders, the R&D, they can do better so that by the end, if not all, but most of the patients, they can afford it and can take advantage of that. By saying that, I'm not going to point out which one, so which panelists want to come up, hear the idea, they could do better this so that we will be in much better position to do that. So do you have that statement, any panelists?
Well, could you repeat your question? I'm sorry, I lost it.
That's $1 million question. We may have a word, 1 million. If that's
Yes.
not in dollar, it's
I
going to be Japanese yuan or Korean yuan. Okay.
I would just leave it up to questions. I think that we have a lot of development in knowing cancer and developing a lot of treatment for cancer. I would say aside from that, stem cell therapy, it has been actually, I would say that there's a lot of centers in San Diego area that Mayo Clinic even opened there. And then I can't remember, I think time of Bush have stopped these studies. Then the time of Obama, it came back to the market. And so we do have a lot of therapy and answers for breast cancers, for all type of lymphomas and leukemias. And I think the market is open, and despite of the fact that the cancer therapy is very expensive, but there are affordability, and we see a lot of insurance company, when it comes to see a patient that there is a hope he could survive, they are helpful. Thank you. Any questions?
Yeah. Well, the panelists come up to with their inspiration. The audience can ask a question at the end, or you can raise your hand and say, here's the thought. I think we could try this to make things more sustainable. So feel free, please go ahead. You knock a little bit to see whether we can hear you.
About the cancer. Is there something we are doing which can find out at earlier stage itself or prevent to the cancer? Because we have seen after COVID, lots of cases are increasing about the cancer. So is there any specific reason? So there are two questions in this. One is, are we doing something for prevention of cancer? Second is there any specific reason after COVID incidents, the cancer cases are increasing a lot?
Well, actually, I could answer that to you. There's a lot of recognition as physicians is preventive measures, in all types of cancer. For example, breast cancer, there's a lot of education to the patient how to go and do self-examination. A patient or a person have to go routinely do tests to identify if there is indication he or she has cancer. That has been implemented for years in United States. And actually now health insurance, they go into medical society and just see if those doctors are doing those simple preventive measures to find out if they are finding cancers early in their stages. So it's not like it has not been happening, it has been happening. Now, the second part of your question is why cancer is increasing. And it is definitely very obvious. What we eat, what we put in our body is one of the main factors. Had anybody pointed out, is that the main factor? The answer, we don't. But there are many studies nowadays talking about the bottled water, for example. I remember my daughter when she was going to UC San Diego, and she was going to go for medicine program, and the dean of the school was having a study about the bottled water that they use some kind of particles like similar preservatives, similar to I can't remember the particles that they use that, it preserves your tissues. But then the bottled water companies have fought him and he couldn't continue with his program. Nowadays, they're talking so much about it, that the bottled water is not as safe as we all think. And there are many incidents that talked about also some kind of like the shelf, the food on the shelves. I mean, a lot of people are not investigating that. And I remember an incident years ago, like dog food caused blindness, and when they discovered that is the material they put to preserve the food to stay long enough on the shelf have caused that blindness in dogs. So definitely what we put on our body, we are not pinpointing it because of the industry of preserving the food. Years ago, we went to the market, we have the food fresh, we slaughter the animal, we have different methods of eating. Now, we depend on everything is put in plastic or in the freezer. What do you expect? Of course, that the daily split of the cells in your body are not nurtured in the normal way that God have taught us. You see, that's a simple answer to you.
So
Yeah.
how COVID is impacting there? After COVID, is there any specific reason? Only food or water, or COVID has also some impact on the body?
Well, I wouldn't say COVID. COVID is actually a virus, but when it attacked the immune system. And I would say immune system is the first system that if you hit it, you end up with cancer easy. So have COVID caused big dramatic change in human. There's no doubt about it. But have it caused anything has to do with us being more susceptible to cancer? Well, I didn't see any new studies, but for sure there is something going on.
Yeah, very good point. And thank you for the question because I think you open the door for a bigger scope of discussion because just take cancer by itself, there are genetic factor, there are environmental factor, and we also have a panelist who cannot come today because he happened to have a flu. And that's Andre. He is in early cancer diagnosis business, so the prevention diagnosis part is also part of the picture play into HEOR and the insurance consideration, population health. By the way, UAE is doing great in the genome and the population health, digital health, okay? So the scope is very rich. So thank you for that question. Thank you. Yeah. So for the panelists, I want to challenge your mind among the journey to develop the whole thing. Oh, sorry.
Yes.
Of course.
This question is for Josh Forst in reference to cancer care in the U.S. How can we make it more accessible to everyone, including Medicare, Medicaid?
It's a great question. We've seen the most success with having more telemed, being able to do a lot more over the phone. And it's been a lot lower of a cost to these patients because they're just doing it virtually. And then when they need to actually get a treatment or a therapy, they go in and make sure that that's what they need and then receive the care. But that's reduced the barrier to entry. And then more insurances are now covering these therapies without prior authorizations being needed, which I think are completely unnecessary. I mean, somebody needs life-saving treatment. You shouldn't have to go through hurdles to get it done. So I've seen that be pretty successful from that standpoint, lowering the hurdle that way.
Thank you, Josh. I hope that one covered part of the question, okay? We also want to pay attention to the regulatory aspect. And in US, that's FDA. In EU, you also have counterparty either earlier or a little bit one step behind, either way. So, what's going on in Italy or EU on the regulatory for the innovative new treatment? So, do you have any impression of the trend?
Yes, for new treatment, we have to do all the research, the ethic commitment, and we can start with new therapies.
Yeah, the EU regulation, when the new treatment like this to cancer highly useful, are they make things easier, faster, or they are way too cautious, take way too many time or way too much cost to review the stuff? So what is your take on the EU side?
Nowadays, if I have particular patients that needs a new treatment, the only way is to refer is to a big center.
Yeah.
Because we have a lot of hospital in Italy, and we do all, but there are some big centers that do the best treatment for this kind of cancer.
Yeah.
For example, in my hospital, we don't do surgery for esophageal cancer.
Yeah.
Esophageal cancer is only referred in centers that do a lot of surgery of esophageal.
Right, right.
And I think is a good kind of work, because the problem is not if I can do or not this kind of surgery.
Right.
The problem is if I have a complication, I can treat it or not.
Right.
In a big center, statistical point of view, I do a surgery, I have one complication every 100. If I do 10 surgery a year, if I have one complication, is a problem.
Right.
If I do the same surgery 1,000 a year,
Yeah.
if I have a complication, I can treat it.
Yeah, that's the cost of economy. You lower the cost if you have the volume, right? So which sounds promising, because among the cancers, some of them have bigger segment of population. Some of them is more rare disease, which are currently on TV. So what I heard from the European regulation, the things going on okay. They may have space to improve, but they are not making things too difficult for the clinician and the patient, right? Yeah. So for the HEOR, I'm not familiar with the scope of your research. So what is your take on affordability? Because R&D, manufacture for the latest cancer treatment, they are quite expensive. So do you have the feeling that the stakeholder, pharmaceutical company, or whoever involved can lower the cost by continue putting to new wave of innovation?
Yeah, as you said that R&D cost is super high, and to lower down the cost, it's always going to be tricky, because it's not just only R&D, it's also about the barrier of getting the regulatory approval as well, and to cross that particular border is also always a challenge. So in terms of there's a case that it cannot be go down, the cost cannot be go down, then how the innovation can go on and patients can afford those treatments. So that's the question. And from the policymaker side, if I talk about the, say, European setup, a European regulatory framework where it's majorly as a public healthcare system. So in that particular case, what as a HUR we are trying to explore is alternative payment system. So for example, one of the payment system is risk sharing agreement, where manufacturers and the payers both are kind of in the same loop of saying that, let's share the risk. So one of the example is the UK, where cancer drug fund is there, which means that the innovative cancer therapy gets approval. Maybe it is not cost effective, maybe it is not showing a long term, maybe the data is very immature, but it gets approval because it has showed in a short term that it is super efficacious, and the safety profile is good, and the patient ethical perspective is also come into the picture, that it is the rarity of the disease, the rarity of that particular cancer indication, and it has to be good for the patient. So what cancer drug fund do that, okay, for 1 year or 2 years, let's have this particular drug in the kitty, like as a reimbursement. During that particular time, the more real world evidence is getting collected, more data is getting collected to understand the behavior and understand the efficacy and effectiveness of that drug. And if in that 2 years, and here what is happening is a risk sharing happening, like payers is saying that, okay, we are going to reimburse, but conditional on this, and let's see after 2 years what happened in terms of real world evidence. So that's the one part. There is another payment model which is getting explored, is subscription based, and in a layman language, it's kind of a Netflix style model, where it is saying that, okay, you show the value of the drug, you show the value of the drug in terms of a long-term effectiveness, you show the value of the drug in the safety. We are going to give you the lump sum amount, this particular for as an annual subscription, and it depends on if it is been given to the patient or not given to the patient, and maybe it put as a reserve. And this particular model, one of the example is again, not from the cancer, but coming from the antibiotic space, where it is very important to keep the drug, because more antibiotics will come out, its resistance will be there, and then that will be a challenge. So it is, in that case, you cannot have the volume-based. It can be a value-based, and that is how the whole different kind of model is getting explored.
Exactly,
and we are
I
trying
agree
to do
with
that
you.
here.
Thank you for your insight, Tushar. We have time, only 1 or 2 minutes, maybe for the last question, please.
Sounds good. Firstly, just wanted to say thank you for the very high-value discussion. That was incredible. My name is Dr. Kandaloft. I work as a primary care attending up in Connecticut. My question, and one of the challenges that I see with my patients is, one of the challenges that I've noticed with some of my patients is getting appropriate genetic panel testing as well, with the appropriate social history, family history, the structuring itself, but also the screening aspect, even when somebody doesn't necessarily have that family history, either approval in through insurance, going in through the system, or finding a company that's able to do it within a decent time around as well, including the screening that follows. Just want to open that to the panel. As a
Yeah,
question.
I would say yes, genetic testing is very kind of valuable tool, and a lot of insurance companies are not fond of it, and it takes a lot of hard work to get approval for that, especially if you have a high HMO in your community, and that becomes sort of impossible to have. But I think it is becoming more prevalent nowadays, especially for kids, and for kind of familiar breast cancers, like if you have more than one person that in the family have breast cancer, now genetic testing is just becoming more approved for insurance. As being the chief medical officer in our society, it is very hard, especially we have high HMO in the area, and we get a lot of kind of requests by patients and by doctors, to push the insurance. And it depends on, nowadays insurance companies are really reluctant to do it, but they are being pushed to approve most of those. But there's nothing I could say more than you have your medical society have to lobby for that, and you have to have somebody negotiate the contracts with the insurance companies to force them to approve such testing, and not only approve such testing, to approve kind of like, aside from testing, the treatment for those patients. Because like we have the same problems in our county, but we have to renegotiate the contracts.
Yeah. Thank you for the answer. In fact, there are much more detail to continue for the discussion, but because of the time, we wrap up our panel for the moment, and feel free to reach out to the panelists after the conference, and I assume everybody may come back tomorrow and day 3. So get your opportunity to talk to the smartest mind in the room on individual topic, okay? To recap, the innovative aspect of the cancer treatment and other disease treatment, both from regulatory, R&D, commercialization, it is good and also bring up challenge. The good news is it can treat more and more disease, okay? Can satisfy the need for a lot of patients. The cautious side is, how about the cost? Who are going to pay for that? So we are not going to bankrupt the insurance for sure, okay? So we need to be reasonable and sustainable. To make things work, there's many factors or gaps we can explore and leverage each other. For example, people in the room are international audience. Part of the world, in some country, your labor cost, manufacturer cost is very affordable. In the United States, we don't have that. what kind of model we can work together to make things more affordable, sustainable. So that's something to think about and also take advantage for discussion. By saying that, we thank you all the panelists and the audience engaged in this interesting discussion. We are going to be happy to talk with you more after this session and tomorrow, the day after. Thank you very much.
Thank you.
That was definitely a very impactful discussion. Thank you so much, everybody. You can exit the stage to your right. And, you know, cancer is such a sensitive topic, and it still baffles my brain how us humans can send other humans into space and they can live quite peacefully in no gravity, yet the cure for cancer is not there, or at least we don't know about it, yeah?